So Rana is going to start the recording for us. And I'm going to go ahead and get started. Today's webinar is on impact of opioid misuse, perspectives from an infant-toddler lens.
Turn it off.
I am your facilitator today. My name is Jean Van Orstel, and I am the infant-toddler specialist from Region 5 and Region 6. And I'd like to welcome you to today's webinar. For housekeeping purposes, if you have any questions, please post them in the chat. We have provided audio tips for you in the box in the upper right. If you have just joined, please dial *6 to mute your phone when you are not speaking so that we do not have the background noise. We really appreciate that. And or mute your phone from your dial pad. If you have questions throughout today's webinar, we ask that you put them in the chat box, and we will try very hard to get to all of your questions. Any questions that we don't get to today, we will be sure to take those questions back and respond to you via email. So we will get some resources and other materials out to you. To better understand who is joining today, we would like to start by having a poll to click so that you can share what your role is and which role fits you best. If you would take just a minute to fill out this poll for us, we'd really like to see who's all here today. We have a lot of direct service practitioners, child care, home visiting, and teachers, preschool. That's wonderful. And training and technical assistance professionals as well. Great. We're just going to give you just a few more seconds to enter which roles fit you best, and then we're going to move on because we have a lot of content to cover today. Great, Rana. Thank you so much for taking care of that poll. And I do want to acknowledge that Rana Schaefer, who is the Region 1 Infant-Toddler Specialist, is really helping support this webinar today. And she is going to be answering things in the chat box and making sure that I don't miss any questions that need to be addressed, and also helping with the polls today. So thank you so much, Rana. Again, if you've just joined, please dial *6 and mute your phone so that we are not hearing the background noise, and we really appreciate that. So the outcomes of today's webinar is we're going to be thinking through and looking at building awareness of the seriousness of opioid misuse in the United States, examining neonatal abstinence syndrome and caregiving approaches for infants born with NAS, and providing strategies for supporting infants and toddlers and their families impacted by opioid misuse. One of the things that I hope that you will hear throughout this presentation today is that opioid misuse is really about a medical disorder. And it is, when we talk about neonatal abstinence syndrome, it is a condition, and it is not an addiction, because an addiction by definition means a person persists in compulsive drug use. So we talk about it as neonatal abstinence syndrome because we want to make sure that there is no stigma attached to this. The withdrawal for infants is something that happens when they no longer have that drug in their system. So moving on, how does this connect to CCDF plans? So our Child Care Development Fund plans, we know that opioid misuse is a priority of HHS and ACF, so Health and Human Services and Administration of Children and Families. And we know that privacy policies within states are going to be important because 12-month eligibility for foster care and increased caseloads for family care and protective services are going to be very important for these families who might be dealing with opioid misuse within their family. Partnerships with other agencies such as TANF, child welfare are going to be important. Professional development, states can make targeted training available for the workforce on topics that will relate to this. And high-quality child care for low-income children. We know that all children need quality care. And making sure that families impacted by opioid misuse and have comprehensive services is crucial. So we'd like to do a poll and find out, have you worked with a family or child impacted by opioids? So please vote. So as we look at the numbers, we see that about half of our audience today, half of our participants, have in one way or another worked with families, a family or families or children impacted by opioids. That is not at all unexpected because we are seeing more and more of this impact across our system and across the United States. So this kind of is telling of how important this topic is. Rhonda, you can go ahead and end that poll and we'll go back. Thank you. So let's look at the numbers. In 2016, 116 people died every day from opioid-related drug overdoses. 11.5 million people misused prescription opioids. So just those numbers alone show what an impact this epidemic has had on the United States. And we know that opioids include prescribed pain medications such as oxycodone, hydrocodone, morphine, methadone, fentanyl, as well as illegal drugs such as heroin and illegally manufactured fentanyl. So, as we move forward, what do we know about the opioid crisis? Well, roughly 21 to 29% of patients prescribed opioids for chronic pain. That could be someone who's experienced a car accident, someone who's had tooth surgery, or someone who has perhaps had an injury such as they have fallen and hurt their knee or their hip. So roughly 21 to 29% of those patients prescribed opioids for chronic pain will misuse them. That was a surprising statistic to me when I first saw it, but then it started to make sense as to why the opioid crisis has become such a crisis. As you look at the next number, 8 to 12% develop an opioid use disorder. And approximately 80% of people who use heroin for the first time misused prescription opioids. Wow. Keep in mind that opioid use disorder is a disease. As the use of opioids increases, dramatic changes take place in brain function. And there is an increased desire and planning on how to get opioids. It becomes an obsession. These changes to the brain are caused by opioid use disorder. Neuroscientists have concluded that it is a chronic brain disease. So this is a medical condition precipitated by long-term changes in the biological structure of the brain. So now we understand that a person doesn't choose to have this disorder. It is truly a disorder that comes about over time, and it can happen with as little as one use of opioids. So it's really important to know the facts. As we look at the opioid-related overdose death rates, you can see in this table the states. These are the top 10 states with the highest opioid-related overdose death rates. And so the highest number is 43.4 persons per 100,000 in their population in that state died in 2016 related to an opioid-related overdose death. It's a pretty high number. And the other column is about the prescription rates. And so we see here in this table that some states have opioid prescription rates that average just over one prescription per person that live in that state. That's a pretty high number of prescriptions. And we know that there's some connection to that. And so there is a lot of education that is going on right now for the medical field about the prescription rates and about options other than opioids for pain management. The other thing that I would say about this particular slide is that we look at the opioid-related overdose deaths, you need to keep in mind that those numbers are actually higher than the number of folks who died in car accidents in 2016. So if that kind of puts in perspective how many folks are being impacted and how many of those deaths are taking place and why it's such an issue, that should help kind of guide you with, let's see, if this is over the number of actual car accident deaths, that's a really high number. As we look at this map, it shows the state's opioid-related overdose death rates per 100,000 people, and the states in red have the highest number of overdose death rates as of 2016. So now, you've heard some of the latest statistics, and so with that, how much was your understanding of the seriousness of this epidemic increase? So we see that a little improved and moderately improved are kind of where folks fall. You probably have heard a lot, and in some states you've heard more than others. And I appreciate that you've shared where your understanding has. We don't know specific persons on this. We don't aggregate that information, but we do know that folks, we've got moderately improved and a little improved on this particular poll that are the top two responses. So we're going to go ahead and end that poll and move into neonatal abstinence syndrome. And why is this important? Is because today we're looking at this topic specifically from the infant-toddler lens. And in this next section of the webinar, we are going to focus on the infants. So neonatal abstinence syndrome is the diagnosis given to babies that are withdrawing from substances that their mothers took during pregnancy. The baby becomes dependent along with the mother while she is pregnant. At birth, the baby is still dependent on the drug. Because the baby is no longer getting the drug after birth, symptoms of withdrawal occur. Symptoms may not occur immediately after birth. It may take 1 to 7 days for symptoms of NAS to manifest in a baby born substance exposed. 55 to 94% of babies exposed to opioids in utero will develop signs of NAS. So that does mean that not all babies will be impacted. One of the other indicators as to whether or not a child will be impacted is that there is a higher rate of impact for children who are exposed multiple times, and it depends too on when they were exposed during pregnancy, how much was used, and which drug was taken during pregnancy. So those are all things to consider as we think about neonatal abstinence syndrome. We know that every 15 minutes, a baby is born suffering from NAS. 5 times as many babies were born with NAS in 2009 as in 2000. The average hospital stay in 2012 for infants exposed to substances was 16.9 days, compared to an average of 2.1 days for an infant not exposed to drugs. So we can see that there is a very strong correlation and impact as to how long a child is going to stay in the hospital. And then, of course, there is residual
I'm going to send this out. This is pretty amazing. This is a thing on opioid impact on infant and toddlers. Yeah.
We're hearing some background noise. If you have not muted your phone, please press *6 and mute your line. We want to make sure that everyone can hear. Great. So the average stay is impacted, and it increases the cost to the hospital and to the insurance companies and quite often to Medicaid for the stay of those folks in the hospital. So what is the possible impact on the development of infants and toddlers? We need
Jean,
to think about this. Yes,
Jean, this is Rana. Before you move on, I have a question for you. Peter would like to know, can an infant get NAS from a mother who uses methadone, Suboxone, or Vivitrol?
So NAS can, yes. So the answer is yes. NAS is something that is experienced with infants who are substance exposed. So yes, that can happen. And quite often infants who are exposed to methadone, and I personally am aware of a case of this where an infant was exposed to methadone and they had to go through NAS withdrawal. So when a child goes through NAS withdrawal, we're going to talk about what that looks like and what the impact is on the infant. And we're going to kind of work through, like, what does that look like in young children? So great question, Peter. Rana, was there any other questions that needed to be addressed?
No, I will keep interrupting you when there is, though.
Great. So what are those short and long-term effects of prenatal exposure? Well, you can see by this chart that infants that may be substance exposed, for infants that may be substance exposed, alcohol actually has the broadest impact on the development of a child. And opioids has the strongest effect on withdrawal itself. All of these substances may impact behavior, but that is not something that we can say for sure. As we know, not every child exposed to a substance will go through NAS, but we know that a majority will. So what are the symptoms of NAS? So as I have trained on this topic and talked with others and really gathered the research and information around this topic, what I've learned is that infants that have been substance exposed and that do experience NAS have disorganized systems. So what that means is that their central nervous system, their digestive system, other systems are in fact not organized as we normally would see or typically would see with an infant. And what this means, if you have not pressed mute, please mute your phone line. I hear some background noise, and I'm sure that you would like privacy as well, as that way we can keep the distraction down to a minimum. So symptoms of NAS include things like body shakes and tremors, seizures, convulsions, overactive reflexes, tight muscle tone, fussiness, excessive crying. Babies going through opioid withdrawal have a distinct way of crying. It's a short, anguished, high-pitched wail repeated over and over. They have poor sucking and feeding reflexes and are slow to gain weight. They could have breathing problems, including breathing really fast. They may have fever, sweating, or blotchy skin, trouble sleeping, lots of yawning, diarrhea or throwing up, and a stuffy nose or sneezing. So you can see how these symptoms are really examples of disorganized systems within their body. And it is especially important for parents to be aware of opiate withdrawal symptoms prior to birth so that they have realistic expectations for developing a relationship with and caring for their child. It may be difficult and disheartening for the mother to soothe and comfort their baby during the early days of withdrawal. The mother's social support network must also understand the implications of prenatal substance misuse and how to best support the new mother and family. And keep in mind that these symptoms will start to go away over time. And we see many of these symptoms go away within the first 6 to 8 weeks. So you may or may not see a child impacted by substance exposure within your program. Instead, you may see some residual implications, or you may not even realize that they went through NAS. One other thing to consider, though, is that symptoms can last for several months. Not always, but they can. So it's important to know all of those pieces as we move through thinking about caring for children who have been substance exposed. So possible impact on toddlers. A toddler who has been
Dean, as
Rhonda, do you have a question?
Yep, I do. As promised, I'm going to interrupt you again. I have 2 questions. Kitty would like to know if bottles are labeled with warnings of the dangers of NAS.
Kitty, that's a good question, and I don't know the answer to that. It's not I'm just, I'm going to put that out there that I don't know for sure. I would hope that the primary care physician would know and the obstetrician would know that their pregnant moms are going to be impacted by opioid use, so they would share that information with them. But I also know that there have been instances where a mother didn't know she was yet pregnant and so she was on an opioid for pain reasons and was exposing her infant without her even being aware that that was happening. So I think that that is a really important point, and I love that you brought it up, that I can only give you that much of an answer. That's what
I have a couple more questions. I do. I have a couple more for you. So Elizabeth would like to know if we have a timeline on how long symptoms can occur.
So, yes, we know that symptoms can occur, let me just, from 1 week to 6 months after birth. But these symptoms do subside over time.
And I have one more question from a couple of people. The question is, does NAS increase the possibility of future addiction? And there are several people interested in that.
You know, I don't know the answer to that. Honestly, I am, as you can imagine, I am not a subject matter expert, although I have done a great deal of research around this topic. And that is a question that I don't know. So I will look up the answer and I will share that out. And that was the perfect segue to making sure you all know that we will be sharing the slide deck, which you can download today in the resource file. We will share the slide deck out as well in an email to all of you that have registered and attended today, as well as we will send you a link to the recording. And in that email, when we send all of that information out, I will be prompted to make sure I have an answer for you, and I will cite the research around that. And I appreciate, Robin, that you asked that question. A great question.
Thank you, Jean. No more questions. Oh, wait a minute. There's another one. There's another one. Should information regarding NAS be shared on registration forms for preschools who attend child care, or for preschoolers who attend child care?
So that's an interesting, Bonnie, that's interesting because we know that parents don't necessarily disclose information regarding things that their child may or may not have been exposed to medically before coming into a child care program, and they are not required to. You can always ask that question, but I don't know that parents would all feel comfortable answering that. I think that what happens, you'll see as we move through this, there are some recommendations around surveillance and screening that may prompt a conversation with parents. So there you go, Peter. You're awesome. I appreciate you.
We had one more question that has gotten a little buried, but I'm going to go back to it. Which drugs cause and have the greatest impact on infants and toddlers?
So when we talk about the opioid use, we talk in generalities of the opioid class of drugs. So I can't say one over another. There might be some research out there about that, but that we are talking about them in the general class of drugs today. So we're going to move on because I am concerned about time, and then we will come back to some more questions, and absolutely, want to address those as we move through. So, possible impact on toddlers. A toddler who has been exposed to opiates may experience one or more of the following symptoms. Now, keep in mind that not all children experience long-term residual effects on themselves regarding, if they were substance exposed. So, and this slide is specific to opiates, because I will tell you that there is a very different set of symptoms that may be experienced by toddlers and infants that are exposed to alcohol over a period of time. So fetal alcohol syndrome is a whole other day's discussion. So thinking through what are those symptoms, we may see mental or motor deficits. We may see cognitive delays, hyperactivity, impulsivity, behavior disorders. We may, but NAS will not directly lead to behavioral issues. The symptoms listed on this slide may occur or they may not, but they are things that could see impacts of opioid use. So I love that there are so many questions, and there's a lot of conversation happening in the chat box around this, because I think that what we're seeing is that there is really a lot of interest in knowing more. And certainly keep that in mind as we move through the training today, and as we move into the latter part, we're going to be asking you what other topics, and if you can just kind of phrase what you're thinking about from this chat box into that webinar question later on, and when we poll, I'd really like to see what might be helpful to you. All right, so how much was your understanding of neonatal abstinence syndrome increase today? We are hearing some background noise, so if you haven't yet muted your line, please star 6, and that way we won't be hearing your conversation. I know it. I always feel bad when somebody. Thank you, Rana. So we are seeing that a lot of folks say moderately improved, and I appreciate that, because there's a lot of information in there and a lot of questions still around this topic, and I appreciate that. So moving forward into the next section, what are the strategies for providing care for infants with NAS? You may or may not have a child that will come into child care, because remember, a majority of infants that go through NAS will have the symptoms will have subsided by 6 weeks, so they're most likely not going to be coming into care with these symptoms. But if they are, there are some specific strategies for providing care. And so we're going to talk about those today. Many of these strategies are useful for all children and all infants, and I really appreciate that someone just said it's important to think about this, because things like what I'm showing you on this particular slide, decreasing environmental stimulus. You know, a room should be a soothing environment, quiet conversation, soft singing, dimly lit room, shades on the window, limiting the people in and out of the room with the infant. I mean, we know these are best practices with all infant rooms. We shouldn't have people running in and out of infant rooms. Avoid picking up infants when they are sleeping. So this particular bullet point was really driven home to me when I saw some videos regarding infants with NAS and their care. And infants, you think about a child who has a disorganized central nervous system, and so when you touch them and they're not expecting it, they are startled, and they are going to reflex because of that. Their startled reflex is highly, it's very, very high. I mean, just very high. I guess I don't know how else to say it. It's extremely high. And so as you think about it, you want to avoid taking up infants when they're sleeping, and you don't want to pat them. You don't want to grab them. You want to make sure you rest your hand gently on them, and then slowly they will be able to become comfortable with your presence and then pick them up. We know that one thing I wanted to share too, and I want to make sure that you understand, is that many infants will require medications to relieve their symptoms at first. And over time, the use of non-medicated strategies will decrease the severity of NAS. And so it's important to support and strengthen parental engagement and attachment and encourage breastfeeding when possible to improve the outcomes for these children. Other things to keep in mind for providing care for infants with NAS are things like integration of sensory stimulation. So as I said, rubbing the infant's back instead of patting. Infant massage may be beneficial. There's been some research around that to show that that is beneficial. Using elevator rocking. Okay, so I have to be honest, I had to look this up when I first saw this because I thought, what is elevator rocking? And it is where the baby faces away from you. So you're holding and supporting the infant away from you, and your movement is up and down. And vertical rocking, which is shown here, which facilitates relaxation and eye contact, where you're holding the infant against you, tummy to tummy, supporting their head, and you're moving forward and back, is vertical rocking. This is so much more soothing than typical rocking or side-to-side rocking, which actually impacts their central nervous system. Swaddling helps them to regulate, and we know that swaddling actually helps them to feel it's a mimic of the fetal position, and it helps them to prevent tremors. It helps to prevent erratic movement, which then helps to promote self-soothing. They may have frequent and small demand on feeding, which may help infants with motor or tone dysregulation. Breastfeeding is important if mom can do it, and it is safe. And using a pacifier, so a non-nutritive sucking, helps to organize a dysregulated infant and encourages them to self-soothe. So it's very important as well. The most important piece of thinking about providing care for infants with NAS is really to be attuned to the infant and adjust to their responses. Some infants with NAS will want to be swaddled. That will be soothing to them, and some will not. So it is so crucial to be attuned to the infant. Also, in all of this, you can imagine caregiver wellness is very important. It is important that caregivers recognize when their anxiety levels are increasing and arrange to take breaks from care. So it is important, whether it's the parent or if it's another caregiver, that they recognize when they're starting to get anxious, because that will be transferred to the infant. So we don't want that anxiety to be transferred. We want to keep it a calm, soothing environment, and it is important to calm yourself down when you are preparing to take care of the baby. So practice mindful calming techniques. These are all important caregiver wellness tips. And using relationship-based practices, which we know are best practice, we we see using these primary caregiving and individualized caregiving techniques are so important for infants with NAS and really supports compassionate and comprehensive family engagement. So what about screening and surveillance? Being able to identify, understand, and respond to the cognitive, behavioral, language, motor, and social and emotional delays that children with prenatal exposure may experience can inform how early childhood programs can best meet the needs of these children. So we can think about all of the best practices we know for screening and surveillance. Children should be observed while they're playing and interacting. There should be a standardized tool used for screening purposes. And if there is a concern, talking with families about a comprehensive prenatal family and early childhood history, talking about your concerns with parents, and that isn't always easy, but having those discussions in a sensitive way is very important. And then when necessary or when needed, using infant early childhood mental health consultation as a tool to help you with working with children that may have been substance exposed. So now that we've moved through all of those strategies, how likely is it that you will use at least one of these strategies or practices if providing for care for an infant with NAS?
And Jean, while people are taking that poll, I want to let you know that there are a number of questions in the chat room. We may not have time for all of them, but I'm tracking them, and we can just let everybody know that we can get back to those questions if we don't have time today in a follow-up email.
Absolutely, and some folks I know joined after I had mentioned that, but we will respond to all questions, and some of them, if we don't have an answer to, we will definitely be working on those questions in conjunction with the National Center on Early Childhood Health and Wellness, who were kind enough to support some of the slide development for today's presentation, and I gratefully acknowledge that. So thank you for taking that poll. Whoop, make it a little bit too big. So how do we support families and caregivers? Well, we know that an increase of opioid misuse has significantly impacted the child welfare system. Infants are coming into protective custody at alarming rates. Grandparents are becoming primary caregivers for a second time. So what can we do? Well, we can increase our family engagement strategies and connect with comprehensive services. What does that look like? Well, let's look at the numbers first of foster care. So we know that the number of children younger than 1 year coming into foster care is increasing and has become the highest percentage by age group of children entering foster care. And you can see the numbers there. It went from 39,697 in 2011 to 47,219 in 2015. While parental substance use disorders is not a new challenge for the child welfare agencies, the current opioid epidemic is proving to have an immeasurable impact on foster care caseloads and child welfare budgets across the country. So we are seeing more and more children coming into the foster care system. So as we look at grandparents, I really found this interesting as I researched and have learned so much about this topic over the last several months. The impact on grandparents is that approximately 2.5 million children are now being raised by grandparents or are in kinship care with no birth parents in the home. That's 3% of all children. And approximately 29% of children in foster care are being raised by relatives. So let's look at this statistic. For every child in foster care with a relative, there are 20 children being raised by grandparents or family members outside of the foster care system. That's a large number of children that are being impacted by this opioid use. And what is happening is that we are now seeing more children in family kinship care where they are now being raised by other family members, or even for a short time are in their care. So how can we support these families and engage in comprehensive services? It's so important to support family attachment and building that attachment. And we know that these children do better when they are cared for by family. So strengthening families is a research-informed approach to increasing family strength, enhancing child development, and reducing the likelihood of child abuse and neglect. It is based on engaging families, programs, and communities in building protective factors. We have several states across the United States that use strengthening families. And so that is one way in which states are addressing supporting families and engaging in comprehensive services. The Incredible Years and other evidence-based parenting programs focus on strengthening parenting competencies, fostering parent involvement. In the Parents and Babies program, parents learn how to help their babies feel loved, safe, and secure, and they encourage their baby's physical and language development. So having these evidence-based parenting programs are another way in which we can support families and engage in comprehensive services. Medical home. So connecting with permission from the family with the child's primary pediatrician or health provider will allow you additional insight into caring for infants who have been substance exposed. Remember that you do need parent permission. In order to do that, you need permission from the family, but medical home is a great place to circle back to when you want some guidance about working with infants who have been substance exposed. Early Head Start. Head Start provides services for young children in a comprehensive manner. And we know that that includes children who may have been substance exposed. And what about early intervention? So there's early intervention, birth to 3, that can help with surveillance and screenings, but also help with resources. And then there's the community resources, things like your child care resource and referral agency. They often have resources and also may be able to connect you to community resources that you may or may not know about. Knowing where your addiction treatment programs are so that you can support families in seeking help when they need it is very important. So finally, the Office of Head Start Parent, Family, and Community Engagement Framework is a research-based approach to supporting children and families and is an interactive tool that is available to everyone on the Early Childhood Learning and Knowledge Center, or ECLIC, website for programs to use to support a focus on goals that families develop alongside program leadership, caregivers, and community partners. So again, it's all about ways in which you can engage with families and support their attachment to their child and support their treatment, and their well-being throughout the child's time in your program. So I hope this information you have heard today is helpful to you in understanding the impact of opioid misuse and the impact that it is having on our youngest children and their families. For more information or other topics related to infant-toddler care, you can reach out to myself or to your infant-toddler specialist in your region. And we have just a few minutes, I see, that we can take a couple of more questions before we move into our final poll and additional resources. So, Rana, do you have maybe 2 questions that I can try to answer?
It will be hard to narrow it down to 2, but I'm going to try. So one question is, for infants that were exposed and resulted in increased spitting up, vomiting, and not gaining weight, what can you do for them, especially when they're not able to have breast milk? So do you want to address that?
So I would tell you that I could not possibly be a subject matter expert on that child. As I'm sure you understand, you probably are not yet, although you are probably much closer than I. Each individual child has a different way that they will be able to respond. And so what I would recommend is talking with the family and really working with them on what has been working for them, for that child. And then if in fact that doesn't result in being able to move forward with improving the situation, because the child should improve over time. And that's one of the things that we have to remember, is we have to give that child time to improve when in regards to the eating and the regulation of those systems. So the other thing that I would recommend is, with the parent's permission, talking with their pediatrician, because I think that they are your subject matter expert in this area, and being able to contact them would be really helpful in this situation. And so I would want to circle back to the medical home, and then again, you would need permission from the parent, but then once you have that, or ask the parent or family if they would ask their pediatrician for recommendations, and have them share that back with you, because that builds your relationship with them as well.
And I see that Jackie has asked if Feeding Matters might have some good resources on this topic. Jackie, I don't know if they would or not, but it's something we can certainly look into.
Absolutely. Great. I appreciate the heads up that that might have something.
And I think maybe one last question was about a weighted blanket. Donna was asking if a light weighted blanket might be helpful for little ones to rest better. And there was a lot of chat about ensuring that you're following safe sleep practices, and that you communicate with your state licensing if you feel a child needs to be swaddled, to see what your licensing allows, and that would be true for a weighted blanket as well. Do you have anything you want to add to that, Jean?
So swaddling, I think going back to that question of swaddling, we know that Caring for Our Children had the recommendation in it that swaddling in a child care program is not always best practice unless it is done appropriately. So I think it is really important to realize that you do need to know how to swaddle correctly in order to swaddle a young child, an infant, and it should not be done after the point at which they can roll, because it becomes dangerous for that child. So it is really important to acknowledge that. I am glad that you all brought that up. As far as a weighted blanket, I know I have heard some of the benefits for young children. Again, I would caution you about safe sleep practices as well, and So if you're using a light blanket to swaddle the infant and it is okay within the guidelines of your licensing to swaddle, then a light blanket for swaddling purposes, yes. I would probably not go with a weighted blanket in that instance, only because I think that you are potentially adding to concerns for safe sleep. And so I would just caution, but you know, we would want to follow safe sleep practices. So I would caution against that. And I agree with you, Nicole. I see your comment, and I just would caution against that because I think that becomes a safe sleep issue. And that's just, again, my personal opinion based on what I know about that topic and having trained on that topic for many years. And that I would defer to the subject matter experts on safe sleep, and that would be Dr. Moon. So we can also take that question back to the Health and Wellness Center. So I see that we are at time, so I want to just quickly give you an opportunity. If there is another webinar topic that would be useful to you, I would ask that you type it in here and go ahead and add those topics, because we certainly want to be responsive. We at the Infant Toddler Specialist Network like to engage in a parallel process. We encourage all of our providers and infant toddler consultants to be responsive and use responsive and reflective practices, and so we do the same. So we really appreciate when you offer out additional topics that would be useful, because we want to be responsive to you. Oh, I love some of these suggestions. Wow. Purple crying. Yeah, good. Rana, I think we have some potential topics to move forward with.
We have a lot of work to do, Jean.
I know. This is exciting.
And I just really loved reading all of the responses in the chat, back and forth in the chat box. Thank you, everybody, for all of those great thoughts and ideas.
Yeah, I didn't get to read all of them, but I am really looking forward to going back and reading them, because I know that that chat box was so busy with comments, and I am so excited that everyone was so actively engaged. This is just really fabulous. Thank you so much. Oh my goodness, look at all of this. I love it. So I do want to let you know, I know we are over time, and let's go back quickly to the presentation, Rana, and then we will, if you have additional topics that we didn't get in there, please let us know. You can always let us know when we send out the email, and we will send it to you or add those to the list. I do want you to know that you will get additional resources. There are resources here listed in the PowerPoint, so you can go here. And all of the citations are on the slide, so if you're trying to find something, you can go there. The Infant Toddler Resource Guide is a great tool that we want you to go to and check out. It is a resource guide that offers a host of materials to support implementation of policies and practices for high-quality infant toddler care. And here is the State Capacity Building Center information. Thank you so much, all of you. I am so impressed with this conversation today, and really, really impressed with all of these great questions that came up and sharing with each other. And I appreciate very much having the opportunity to share this information, so important, with all of you. So you all have a great day, and with that, we will end our call.